funny that you were talking about, Mike, the illegal engine that could. With the latest research in the news, where the guys who are sitting behind the motor, the engine, are the guy that poisons them the most. The recent research from the technion about the little particles that we're breathing, so those who want to sit behind the little engine that could are poisoned. I'm interested in the V to VCO2, and for all of my career in medicals and physiology mixing together, I learn all the time. Cardiopulmonary exercise testing is something that you learn all the time. You learn about your ability, your disability, what you cannot do with it, what you can do, and you learn all the time. Since the time that I went to Omri's lab in 1985, I think it was in Moore Institute, to see this wonder of cardiopulmonary exercise testing as a resemble for sports medicine, until today I'm learning all the time about the cardiopulmonary exercise testing. And that's the beauty of it. And one of the things is that we're still exploring not the initial value that we're getting, the direct, the primary, but it's the secondary parameters that we learn out of it, how to use it, what is the norm. We learn all the time about the norm because we're having other diseases, other cases all the time. And right now, we're having what we call the breakout of heart failure, which we were not familiar with it 10 or 15 years ago, heart failure with preserved ejection fraction. And in fact, there's heart failure with improved ejection fraction, heart failure with preserved ejection fraction. There's so many new terms that are being used in cardiology when I'm coming from in my department. So, and you try to cope with it with a test or the tool that you have in your hand, which is cardiopulmonary exercise testing. You teach the physician how to use it, to refer to the exercise physiologist to do those testing, but you have to also learn how to use those tools in those entities. For instance, if you're trying to work with a heart failure with preserved ejection fraction patient, there's no clear diagnostic test beside the subjective story, what they're telling you, or the fact they are getting into a heart failure, pulmonary edema, and sometimes dying out of it. There's no absolutely clear criteria to diagnose it, and they're using echo criteria, which echo criteria you guys believe in those cardiology that are using it, they're using the best, but are statistics. And the statistics of the cardiologists are based on certain small amount of, and even they criticize themselves for the value they are using it. And here I come with my courage to stand up in those forums and say, why don't you test it with the cardiopulmonary exercise thing? It's available in your department, other places. And they look at me and they realize that there's another tool, another guy in the neighborhood to be able to use it. And this interaction brings you to learn more and more about it. Right now, it brings me to the V to VCO2 and what happens to that specific patient. And right now, what we know about the VE to VCO2, and we'll learn a little bit about it, what we heard today, is I can tell you that it's being used in the cardiology, the criteria. It's very important for them to use, especially those who deal with heart failure with reduced ejection fraction. It's a clear criteria for the heart failure with reduced ejection fraction. In fact, we're going to see it in a few seconds about it. So here we go through this game, the integrated cardiopulmonary exercise testing in the system that work together. I'm not going to extend too much about it. You know about it. It's just a nice description of it. And we're using it for different diseases. We can actually look at different sections of those, the way the cogwheel working together, all those systems, and different diseases are being can be pinpointed and different weak links in this cogwheel chain. So we learn how to use it all the time. What we do is basically doing a very simple thing by looking at the oxygen consumptions and using a very simple equations and trying to cope with all those data that we can come out of this equation, what we can measure and how we can relate it to different diseases. And each one of those parameters, whether we can predict it or measuring it, it's allowing us to learn more about the physiology of the healthy or the disease. In this case, we talk about disease patients. Now, looking at predicted and normal value for test parameters, if we look at those values, you can see that we're having a predictive value, we're having the range, and we can use those predictive value to find out whether we're talking about the cardiac limitation in exercise or ventilatory limitation in exercise, and get the first idea what kind of a patient we're having in front of us when we're actually testing it. And we can see, for example, when we're looking at the value of cardiovascular disease, that the oxygen consumption, which is considered the first one that we're looking at, and the maximal oxygen consumption, that's what Omri insists of, we're looking at the maximum. It's difficult to get those patients to maximum, but we're doing it. So we're looking at those maximum, and we used to see it a different way. We used to see the slope going like this, and suddenly we see a patient with a slope like this, which can tell them about, if you use a secondary, tertiary parameters, dividing oxygen consumption by work rate, and finding out that how sick they are because they're working mostly anaerobic and they're not producing for the same work rate, they're not producing enough oxygen consumption, but they're still exercising, so you see the efficiency will be low as was described before. And this is a clear cut of a patient with a probably cardiovascular disease reaching a 50% of predicted VO2 max, VO2 peak. And this is something we can use for predictions, for prognosis of what's going to happen with your life with the next 10, 15, 20 years that we're talking to patients, whether you should do something about it now or change your lifestyle, take the medication you're supposed to take. So we can talk about patient. Now, the pulmonologists, because we're talking about the breathing test, the pulmonologists are the leading researchers in this field, and one of them is Carl Wasserman. There are a lot of us and other, even in this room, there are at least 2 or 3 people that have been in his lab and met him in his life, that the pulmonologists are pushing it, and they're using it for years for prediction. And we can look at predictions, but they also develop other predictions, and one of the predictions they developed in the beginning, I think it was the gold standard, and this is looking at the dependent on the COPD survival in a Kaplan-Meier analysis by the according to the FEV1. I mean, you can see clearly that you can predict the life of a person, how much and what's going to go on with his survival or prognosis goes down as his disease is severe, highly severe. The more severe the disease, the FEV1 is going to be lower, and the survival is going to be also lower. Take a patient. Now, here we come with the cardiopulmonary exercise thing. We say we have a better result. And we find out, as I showed you here, the FEV1 criteria for survival is dependent on morbidity and severity of the disease itself. But if you're looking at the criteria, the same COPD survival, Kaplan-Meier analysis, this time according to VO2 peak, it's independent of morbidity and mortality, and get a better result in predicting their life expectancy or the survival of patients. So we have a better tool in our hand. The VO2 max is also used, the VO2 peak is also used in cardiology for survival of heart failure. And here we see the survival, Weber functional classes and event-free survival in heart failure. And again, we see those graphs talking about the Weber A, B, C, and D, and we have those criteria, and how severe is the patient, and whether it's very severe, those patients are referred to cardiac transplant, those patients. So we have a criteria to refer a patient to cardiac transplant, one of the criteria. It took us a while to understand that this is not the only criteria, and we have actually a better criteria. This is becoming to a ventilator equivalent ratio. One of them, I think we were in the introduction talks about both of them. I will skip this slide, but one of the slides that's been used for, one of these parameters that's been used for predictions in cardiology is, skip this, we heard about that. This is the graphic you're also familiar with. One of those, the VE to VCO2, which is my center of my presentation today. Now, looking at the cardiovascular limitation in exercise, we can see here that we saw this graphic, the flat line of the VO2, impaired exercise capacity, and the peak VO2 and the VO2 at the anaerobic thresholds are low, very low. So what's supposed to predict it? You can also see that the high heart rate to begin with a low response, the chronotropic effect is very low, and low oxygen pulse. It's a flat one. The blue line underneath it is the
הגבול הגדול באמצע זה האדום.
Okay. This is the plateau that we're talking about. Instead of going up and then flatten a little bit, it's flat from the beginning. Also, with increased VQ mismatch, the VCO2, we're starting not at the normal level of 25 to 35, what we see. Those patients starting, this patient specifically, is around 40, similar to what we saw in the COPD patient before. But this is not a pulmonary limitation in this case, it's a cardiovascular limitation. And we see hyperventilation because this guy is in shortness of breath and he's breathing his ventilation, trying to compensate for his limited cardiovascular system. That's why you see he's hyperventilated. And when he's hyperventilated, the VE to VCO2 goes up. So here's the slope we're talking about. And this slope is very interesting to me because the more you read about it, the more you become fascinated about the fact that most of the big organizations, the American Heart Association, the European Association, they all talk about this parameter. It all talks about the fact that not being used correctly, but they haven't done anything about it to learn more how to use it in those specific diseases we're talking about. So this number of the slope, and you should understand that this number is right now in the center of what I'm trying to research more and more. What's the significance this number has to be with patients with a heart failure with preserved ejection fraction? And my prediction is, you can see later on, that the parameter can become a very important in diagnosis and prognosis of those specific patients for the reason that I will show in a minute. So here, before we're getting into the exercise training in patients with chronic heart failure, if we train them, for those who are not familiar with what's going on in the cardiac rehab, so we see we can train exercise, we can exercise train patients with chronic heart failure and delay the ventilatory and aerobic thresholds and improve the submaximal exercise performance. As we can see here, in all the parameters, we see an improvement. This is the old news. We see that. Can we understand and take this into practice? Yes, we can. If you're looking at the CPAT value as a prognostic in congestive heart failure, Cora and others, the friends, gave us the values for severity to grade the severity of the disease. And we're actually doing the thing that we are learning to do, taking the RER as much as possible. In clinical world, we are not getting into the 115 or 110, 1.15 or 1.10. We're satisfied if we get those patients 1.05. Sometimes it's a good exercise test, good maximal exercise test. We see a plateau in those patients sometimes. If we actually can motivate them enough, we can see a plateau. And if you are reaching it, you have a maximal test. And looking at the value, we can say that those patients above 18 ml per kilogram per minute consider low risk. They may have ejection fraction of 15 or 20, very low. You can look at the echo and it looks like something that out of this world is not actually contracting in the verb, but they're able to exercise. And although they have an ejection fraction very low, the survival is going to be higher just because they were able functionally to function better and preserve other systems, not just the cardiovascular. Okay? But if you're looking at other patients, this patient may be having ejection fraction of 40%. but he is already in the moderately to severe situation. And now we're looking at the V to VCO2 as a secondary parameter, and looking at the slope. The slope above 34.5 or 35 according to Cora is actually what divided those patients, those group, into moderate risk or high risk. Now remember, I'm interested in the preserved ejection fraction. In this case, it's a patient with reduced ejection fraction. We didn't reach yet to the preserved ejection fraction. And of course, those who are having very low oxygen consumption, maximum oxygen consumption, are considered high risk, no matter what VE to VCO2 they have. So this is being used, and actually if you send a patient to evaluation and you think he may need cardiac transplant or at least LVAD, left ventricular assisting device, which is those guys who are walking with a battery and the little motors in a little bed, they're actually having their heart being assisted by a mechanical system that have all those tubes going inside their chest into their heart. They don't pull those bags, they have to go with those bags all the time. And they're exercising with it. That's nice to see how they're exercising with it. Try to take a blood pressure from those patients, measure blood pressure from those patients or heart rate. You don't have those results. You have a motor that's been using, you can see those. You're actually looking at the machine, like looking at the car, very quiet one car, hybrid type that's working, and you see the revolving, how much this pump is revolving, and this is what keeps him alive. This guy having a very severe heart failure without this assisting device, he will die, and he got this LVAD to bridge over the time until he get a heart in the cardiac transplant. Some of them stay with it for years because they keep him in a better shape. So this is the criteria that we've used before, as I said, by Cora. Now we're looking at another criteria that we're looking at, and we see the value that's important for us in our evaluation. We see the peak VO2 below 14, before there was below 10 or 8, between 10 and 18. You will see the risk value, risk ratio, and we can see what are those criteria important. Below 14, below 50% of the predicted, VE to VCO2 above 34, and VO2 at anaerobic threshold below 11. And we're using it at the lab for testing those patients as an evaluation before transplant or left ventricular assisting device. Coming from this heart failure with reduced ejection fraction, as I said, I was interested in what we can do more with these parameters. And how we can use it in the other cases. In this case, there is analysis and a new study that look at the how predictive the VE to VCO2 slope can be used in congestive heart failure, and we use the ROC analysis, which is a receiver operating parameter characteristics, and to see the contribution. And the way you are looking at those graphics is the area under the curve and how much it's contributing to the result of the parameter you're looking at. And you're getting a result around 0.77, 0.63, and it's being related, it can predict, area under the curve can predict the cardiac-related mortality in those patients and cardiac-related hospitalization of this patient, which is important for the health systems as well as the treating physician. And they are used to accept those numbers around the 60 to 70% contribution to explain the prediction, because it's just the best that they got in heart failure with congestive heart failure. Heart failure with reduced ejection fraction is the same. Same thing if you look at the Cox regression analysis and Kaplan-Meier survival curve. We we're getting a result similar like that. The slope is going down. We're going down, and we're looking at criteria for specifically for cardiac-related mortality. We're looking at the value of about 39. We're looking at cardiac-related hospitalization. The best result is actually when the value around 32.9, around 33. So we have values to be used in the clinical field in heart failure with reduced ejection fraction. Now, CPET is subjective, is significantly objective assessment in heart failure. And the slope that we're looking at are major indices affecting functional capacity and prognosis, as we saw. But using the VO2 for years, it consistently shows a powerful prognostic marker. But there's a limitation to the VO2 flow, the VO2 peak. It may not be accurately found. Not in every test you find the VO2 peak. And this is an important point about the VO2 peak. It's a very good predictor, but it's difficult to reach it and to get an acceptable value that you can use it. And it depends on the maximum. Those patients to reach a maximum is not all the time available. Not all the time you're reaching a plateau and you have your result. This is opposed to the VE to VCO2 value, which found out to be equivalent to superior objective prognostic value, because you don't have to reach the maximum. You can do it in almost every patient, providing that you have the criteria. So far, the criteria that we have is only for heart failure with reduced ejection fraction. We don't have them for the large community of patients with a heart failure with preserved ejection fraction. And how many heart failure with preserved ejection fraction do you think you have among the heart failure community? What percentages of patients this section of heart failure with preserved ejection fraction will take in this large size of community? If you don't know, the heart failure community is actually the most growing community in the world, as opposed to the secondary to the aging community. So we have more aging people, but we're having a lot more heart failure patients. So what percentage do you think we're having of those patients with preserved ejection out of the total heart failure patient? No. Not the number. It's half 50% or more. So there's more patients of that are working, and they're not being diagnosed correctly. Now you have the tool to try to diagnose them. Those patients are usually our older patients, patients with hypertension, diabetes, obesity. And there are so many that the criteria is not adapted to all of them. So the optimal, we saw the optimal for cardiac-related mortality was around the value around 39, and for the hospitalization around 32. And beta blockers and other medication affecting it. And here we come to a study which I started to look recently. Look at this. This was just last year. A combined exercise stress echo with cardiopulmonary exercise testing. But you know a place in Israel they're doing it combined testing like that? Only one place that's been doing it in Israel so far. Yeah. This is an excellent test. But this is something that you can do. You have it in every lab in the hospital. You have both of them, just they're sitting in a separate unit. You have to work together. And believe me, it's difficult to put them together. This study comes from somewhere in the Yugoslavia groups. And they look at the combined exercise stress echo and cardiopulmonary to identify a masked heart failure preserved ejection fraction patient with hypertension, which means looking at the patient that he's normal at rest. His only complaint is dyspnea during exercise, certain exercise, light exercise, no problem. You start to walk stairs, something like that. Looking at this echo, his echo at rest is normal. So what do you think? Why are you talking about the heart failure with a patient with having a normal echo and normal other parameters? And you start to exercising when you find out that he's creating a dynamic situation. And this group will use it on 87 patients with 54 men, 33 women, excluded all those having a reduced ejection fraction, of course. They took only those above 50%. They took off everybody that been known to have preserved ejection, heart failure with preserved ejection fraction. They don't want to know the one that were already been diagnosed. They took only those that look like normal. Just the complaint is they're having severe, they took off severe hypertension and cardiomyopathies. Medication can be used, and you see the medication, all those medications in patients will be talking about. We talk about hypertensive patients using medication, as you can see here. And the target was to reveal diagnostic abnormality, not evidence at work, at rest, excuse me. And the value here that we're talking about in echo, consider today as a gold standard in echo, and remember this is a statistic number, was found in about 9.2% of the patients that were tested. Those with mask, without mask, assuming without mask, heart failure with preserved ejection fraction had a higher VO2 at ventilator anaerobic threshold, have a higher peak VO2, and have a higher O2 pulse. Those with masked hypertension, those 9% of patients, have increased VE to VCO2 slope, significantly increased. What we see in pathological situation, whether it's COPD or heart failure, other question, we can look at the other parameters, but this is 35 as opposed to 25. They have a poor decrease, that's a mistake, in PET CO2 at the end. And they look a lot thicker, and you don't predict it from the resting value. Peak VO2 is lower, the peak PET CO2 is lower, which means that actually this is low functional capacity. This is how much they push the ventilatory system to compensate about the problem. That's why they're reducing the end-tidal CO2. This is how high the ventilation work to compensate again for the cardiovascular. So they're having a poor situation consistent with early result that's been shown before about the relationship between V to VCO2 slope. And they consider it as a powerful prognostic marker for heart failure with preserved ejection fraction. This is a small study. This is one of the first, if not the first, that I actually saw in literature talking about trying to diagnose a patient without a diagnosis at that point, and they trying to diagnose it and put it in the entity of heart failure with preserved ejection fraction. Now, you talk to a patient like that after a test like that, try to explain to the guy who is having a normal, excuse me, thank you. Trying to explain to him that, excuse me, mister, but you have a heart failure, and you feel normal. It's like almost like telling somebody you have a cancer when you never thought about it. What did I do about it? Good question. What's the prognosis of this? Good question. All those things have to be learned how to use, and the idea for it, I will try to skip this table. This table shows the characteristics of those patients. Again, remember, we saw the ROC analysis before, the receiver operating characteristic before, and we saw acceptable ROC analysis with about 70 to 60 that look like this in the area of here. Here, in this specific study, the ROC analysis is close to 99%. It's very close to 100%, with 100% sensitivity, right? 100% sensitivity here, and 90-something specificity. Yes, 100% sensitivity, 91% specificity, and this, if you can read it, is 1 minus specificity. That's why it goes to 0. You see? So with 1 here, sensitivity, and 1 minus 0.91, bring it here, and all this area accounted for the variability of what you see in the test, which consider a very good, the best multivariate predictor for masked heart failure with preserved ejection fraction. So we have a new tool from an old test to use in a new entity of a disease that's been emerged for the last 10 years, and we have to learn how to use it. Can we use it for diagnosis? According to this study, only study that's so far in the literature, yes. The answer is yes. Gauzy, whoever goes to the European Association of Cardiovascular Pulmonary Rehabilitation seminars, they're having a seminar on cardiopulmonary exercise testing, right? Andy, you are teaching one of those in Verona. So I'm actually promoting it right now. If you're interested in that. They talk about, I don't think you guys are going to talk about it. This is news, very new. I don't know if you're going to reach it, but I recommend that you start looking at that as well, something to teach in your workshop as well. Gauzy teaching one of those workshops, and he found one of those, in one of these tests, he was looking at this parameter, yet not as good as the last one that I presented, but he found that the relationship between the tissue Doppler imaging at rest and cardiopulmonary testing of variables. He tested in a group of 30 patients. Later on was a bigger group that he used, and he found those significant correlation between the value of the E to E prime at rest with and looking at rest, right? We're talking about the rest. So he found patient with resting diagnostic value of heart failure with preserved ejection fraction. The group that I presented was looking at the patients that don't have a diagnostic like that at rest. They have a normal value at rest. Only were considered during exercise to develop the heart failure with preserved ejection fraction. So the superiority of the V to VCO2 slope versus the peak VO2 in heart failure with preserved ejection fraction become clear more and more. And this group that I presented before is opening the door for other research on this area. This is the best multivariate predictor for masked heart failure with preserved ejection fraction with a cutoff point around 33. And the idea behind it, now closing my remarks, is that when you have increased slope during exercise, and we see an increased slope of the V to VCO2 during exercise in heart failure patient, it means that you have a higher VQ mismatch. A higher VQ mismatch is a higher ventilation to perfusion. And we're looking at those who are not familiar with it, we equivalent of the perfusion to the VCO2 because CO2 is so freely, it's diffused very easily through the capillaries. There's no almost limitation for it, unless you have a very thick membrane to cross for it, but in most cases it's go freely. So the more blood going over the perfusion, the higher the VCO2 will be. That's why you can look at those as a resemble of the perfusion. And there is a normal VQ mismatch. In every lung, in every person here, there's normal mismatch. But abnormal mismatch, which means it's increased, abnormal mismatch is moving from the normal level of 35, 25 to 35 and above it. This abnormal value can help in diagnosing patient with something new and creating a ventilatory limitation.
Okay.
So what I brought here is initials, and I recommend for any exercise physiologist in this room that learning how to use it. As I said, I'm still learning all the time about how to use this cardiopulmonary exercise testing. To look at what you have in his hand and realize what he can do with it. And that's the way you create research. For me, it's relatively new because I'm looking at this value for years, and I see those values goes up at the end of the exercise is more than they are in the middle of the exercise. Why do we measure the whole section? pick up the phone, I call the company that working my equipment. I ask them, how do I change the measurement? I don't want to measure the whole slope. I want to measure the slope from the beginning to the ventilator anaerobic threshold, from the ventilator threshold 1 to ventilator threshold 2 to the compensation point, and then from that to the end. See which slope is even better predictor of something that we are talking about for diagnostic. Thank you very much.